everybody. Thank you so much for having me. I am the Neuroimmuno-Oncology Fellow, which is just like a fancy way of saying that I am the fellow who oversees the CAR T trial at Stanford Children's. And Lisa Ward reached out to me and asked me to speak a little bit about our clinical trial, recent updates from the new arm. And then she also wanted me, Lisa Ward's actually about to join us. And so Lisa also wanted me to talk a little bit about palliative care and some of those considerations when you're facing a diagnosis of DIPG. So thank you all. It's lovely to see your face, Lisa. Sorry, I just want to say hello.
So good to see yours.
So I just have a few slides, and then I thought that I could start with this slideshow, and then we could answer any questions that you guys have and just talk about anything that's on your mind. So I kind of wanted to go through the process of navigating the world of diffuse intrinsic pontine gliomas, and really to underscore that there are many pathways to facing this diagnosis, and it's a lifelong journey, and there's no right way of doing it. And so you just have to find what works for you and your family. And I will go into some of a background about the tumor in case you have children nearby and you don't want them to hear more specifics. So as you all probably know, diffuse intrinsic pontine gliomas account for around half of all pediatric high-grade gliomas, and it affects around 200 to 400 children every year. And although it's only 200 to 400 children, it actually accounts for 24,000 life years lost annually in the US. Median age of diagnosis is 7 years, and it's the leading cause of brain tumor death in children. The median survival is around 10 months, and then the progression-free survival is around 7 months. And once patients progress, things typically go very quickly, and there's only a 3 months post-progression survival. Thus far, radiation is the only definitive treatment, and that's the standard of care. But as many of you know, there's a variety of clinical trial options that are trying to alter and optimize and prolong life for these children. These include CAR T therapy, which is now occurring at multiple institutions across the US, metabolites like ONC201 and ONC206. There's monoclonal antibodies, oncolytic viruses, as well as convention-enhanced delivery of chemotherapy agents like panobinostat. And so I wanted to touch base about our clinical trial just for a few moments, because I imagine it's a very tight-knit community and there's probably a lot of word about the different CAR T trials. So I wanted to talk about what makes our trial a little bit different from the others. So we use GD2 CAR T therapy, and we are only treating patients with H3K27 mutated DIPGs and DMGs. We are currently only treating patients through an ICV, or what we call intracerebral ventricular, where we insert the CAR T cells directly into the brain through the ventricles. We do infusions every 4 to 6 weeks, and it's a combination of inpatient and outpatient monitoring for these patients. And there are an array of toxicities associated with this CAR T therapy, including cytokine release syndrome, which is associated with fevers, decreased oxygen levels, and decreased blood pressure. You can also have what we call immune effector cell-associated neurotoxicity, where you can become a little bit altered, have some changes in your writing, and sometimes can have seizures. And then we have tumor inflammation-associated neurotoxicity, which is really where you have revving up the inflammatory system in the tumor bed, and that causes you to have either changes in your worsening of existing neurologic symptoms or new neurologic symptoms that are transient. And the more dire situations, this can be associated with higher intracranial pressure, but we have safety measures to help control that and to ensure that patients are able to go through the toxicity period without any long-term deficits. And as some of you may know, we recently had a paper published in Nature describing our experiences with the first 4 patients on our trial. And this paper, is chapter 1. And this chapter is so instrumental in setting the foundation for our trial and for optimizing therapies for patients going forward with DIPG. And I just wanted to highlight some of the things because I think there's a lot of curiosity about the results that we've seen, and it has varied. So we see a wide spectrum of clinical and radiographic benefit from the trial. We've had patients having up to 93% reduction in tumor volume, which we can see with this patient who had a spinal cord tumor. And in the beginning, the tumor was this like very long, extending multiple cord levels, and then it grew over time. But then after getting a repeat ICV or through the ventricle infusion, it had reduction in tumor size by quite a lot. And at this point, we've had multiple patients now who've had up to or greater than 90% reduction in clinical and benefit as well. There is this wide spectrum of results because unfortunately, not all patients have both clinical and radiographic benefit, and the duration of that benefit can vary from patient to patient. So for instance, one other patient that we highlighted in this study had slight decrease in the size of her tumor, and she had clinical benefit and increased strength of her right hand, but relatively speaking, this clinical benefit was perhaps not as strong as the clinical benefit that this other patient received who had a more dramatic tumor reduction. So this first stage of the study really helped tell us, okay, how do we treat these children? How can we deliver these therapies safely? What's the cadence of the therapies that we need to deliver? And how can we manage the toxicities so that we can really deliver it on a more long-term basis and hopefully continue to elongate life? And also we want to see like why certain patients respond better than others. And it really has been the donations of these children's like blood and CSF, and in some rare cases, the actual tumor tissue that has allowed us to really identify the different profiles and characteristics that allow for a stronger response to CAR T therapy. And we're very hopeful that we can build upon what we've learned in our first chapter and really begin to help patients have more success with CAR T therapy going forward. I just want to take a pause right now and see like if anyone had any questions about the GD2 CAR T trial or the results that we've seen thus far.
Have you come across any indication on why it works on some and why it works differently on others?
Yes, so because of the tissue that we've been able to obtain from patients as well as the CSF and blood profiles, we've seen that there are certain populations of fighter cells that are activated by the immune system that can be sometimes be good agents, but then sometimes can turn bad and actually make the CAR T cells less effective. And so it's trying to manipulate the specific populations of cells that we're seeing so that we only have the good agents that really rev up the immune system in a way that targets the tumor. And so it's still a work in progress, and we're hopeful that as we begin to treat more patients, we'll see more of those patterns will emerge, and we can perhaps even have interventions to really optimize and change that tumor microenvironment so that would allow for the CAR T cells to be as effective across the board for every patient.
How many patients did you have so far?
We've treated 12 patients thus far. And so we finished the first dose level and the first arm of the study actually. And now we are transitioning to the second arm where we do exclusive ICV infusions. And we are enrolling around 2 to 3 patients every month.
The second phase, you're up to how many patients?
We just opened the second phase about a month ago, and we have 3 patients. So 2 patients enrolled and 1 patient enrolling next week. What
is the max number? That's why I'm asking. Like you can do so many a week. I know I can understand because it's.
So of course, that's an excellent question. The rate limiting step is the manufacturing spots to make the cells themselves. So we only have 2 manufacturing spots every month. And because this is a new arm of the study, there is a safety profile that like you stagger the infusions. And so we currently do not have any open slots for the next couple of months, but what we recommend is that people reach out if they're interested to our GD2 CAR T email, which you can find on clinicaltrials.gov. And then we put you on a wait list, and then it's a constantly moving wait list just because of the nature of the disease. So it's hard to definitively say like how quickly one would be able to get into the trial if they meet the eligibility criteria.
Dr. Mahdi, is the difference between the dosage, can you explain how this arm dosage is escalated over the first arm that you're in?
That's an excellent question. So the very first dose level, it really was about figuring out the max tolerated IV or systemic dose. And then because of some very brave patients who were willing to take on the risk of getting an ICV infusion, we learned that 30 million cells was an appropriate dose that was well tolerated with patients who are getting ICV infusions. So that informed this arm of the study where we will have 30 million, 50 million, and 100 million. And there will be 3 patients who get 30 million cells. And then if everything is safe and people wait the appropriate time after the last infusion and we don't see any toxicities that are dose limiting, then we would escalate to 50 million, and there would still be a staggered effect, and then it would go to 100. We are exploring potential ways to expand one certain dose level in case if there are additional patients who are interested, and we can't necessarily wait to the 100 million dose. But those are the 3 dose levels that we have. And although right now we have 3 patients per that dose level, we have the potential to give more patients on any one of those dose levels if we wanted to.
I have a question.
Mhm.
If the 3 patients that get the 50, is it 50 million?
Mhm.
If they don't have any reactions, would they be able to jump up the next time to the next dose?
Not right away. So we would need to make sure like everyone has to stay within their dose level until we've completed the 3x3. And that at that point we could have escalation, but we can't have intra-patient escalation within the dose level.
Got it. Thank you.
Of course. Any other questions right now?
I was wondering, with the dose level, does it also depend on other different criteria for dose level, like the size of the tumor or the age of the child?
No, so we have very strict eligibility criteria before we consent to enroll a patient, but and that includes like not having bulky cerebellar or thalamic disease, having an appropriate clinical functional status, which the neuro-oncologists will, they define in their exams, and then having a definitive diagnosis of an H3K27 mutation per biopsy, and not having any evidence of dysphagia, which is trouble swallowing. So as long as people meet those criteria and have had the appropriate washouts from prior chemotherapies and radiation, then they are able to get any of the dose levels.
Does there seem to be any correlation between how early after the first 30 rounds of radiation and starting this trial has with success?
It does. So we feel that as soon as patients are done with radiation, that is like the best time to come get a CAR T infusion, just because it really primes the microenvironment so that we think that patients have the best response to CAR T cells. So we wait 4 weeks after radiation to begin CAR T treatment, just because there is such inflammation with radiation, and we want to make sure that it's safe to proceed with another therapy that would also cause inflammation. And then we think that that's like the best time to hit it, and then we keep hitting it every 4 to 6 weeks, because if we've seen that when we wait longer than 4 to 6 weeks, then the race between the tumor and the CAR T cells is a little bit more difficult to navigate, and the tumor can sometimes outpace it and win. And so we feel like if we continue to provide repeat infusions, we're able to stay ahead of the tumor cell growing.
So you saw this with your publication, the patients that came out of radiation did better than the ones that didn't on your 12 first arm, or?
Well, all our patients had to complete radiation before they were enrolled. So we didn't have a patient who did not have radiation.
Yeah, but the ones that went directly from radiation before entering any other trial within 4 weeks of radiation, if that was confirmed with those first 12 you did.
It was. So patients who came to us after like a year of other treatments, it was harder to get ahead of the disease. And even a few months. So the key thing is that to catch a patient before they start having evidence of tumor progression. Because once the tumor begins to progress, then it's harder to control and get ahead of the tumor, unfortunately.
I just wanted to share for everybody that's on. So Dr. Mahdi, you can absolutely use Jace by name or refer to him in any way. But our son Jace was, I think, patient number 2 on the CAR T cell trial. I think in the paper you get to see his smile, which warms my heart. But he came after 14 months of treatment with ONC201. He was starting progression. He had a great response in his first dose, which was through IV. They did not know quite how long to wait before a next dosing, and that's okay. That's part of it. So he was progressing pretty rapidly when he had his second dose, and he went from barely being able, to walk into the hospital, really using a wheelchair to get up to the floor, to walking 3 to 4 miles at the Super Bowl 2 weeks after he left in the second dose with a full straight smile. He did have a total of 5 infusions, and he had always had some evidence of microbleeds. And after his 5th infusion, everything looked good. We came home, but he did experience a brain bleed, not necessarily related to the trial. We knew that that was always going to be a risk. And I know of many older boys that have met their demise in that way. So I just wanted to be very open in sharing. We think the world of Dr. Mahdi and the entire team, but I also wanted you to feel comfortable talking, about anything, Dr. Mahdi, with me on the call.
I appreciate it. I didn't want to bring it up in case it was.
This is how sensitive and wonderful the team is. I can't tell you enough how well the children and families are taken care of at Stanford.
Well, it's our honor to take care of him. And Jace was instrumental. Like when I refer to tissue collection, everything, Jace was gracious enough and his family was gracious enough to donate his brain to our study. And it's because of him that we were able to identify that there are certain populations of cells that are more predominant in people who do well compared to those who don't respond as well to CAR T therapy. And Jace was the first one to do, it was a game for getting an ICV infusion, and that's how we learned that this was something safe. And it was because of Jace that we learned the cadence of how frequently we need to be giving infusions. So the success of the study and any future treatment is because of Jace and kids like him. So we're forever in debt to Lisa Ward and her family.
And Jace learned new vocabulary at Stanford because Child Life gave him 100 words to use instead of cussing during some of those treatments. So it went both ways.
Oh no, I think we learned far more from Jace than he did from us. So if that's all about the GD2 CAR T trial, one of the things that Lisa wanted me to talk about was palliative care. And I think that palliative care is a subject that is often shy, like people are shy to talk about it. It's almost taboo. And I really want to sort of break down any of the misconceptions that we have about palliative care and really emphasize how it can be an integral part of the treatment course. And it can be of immense value to patients and the families as they deal with facing such a terrible, terrible prognosis and disease. And I think I'd like to start off by saying that palliative care is not hospice, and it can completely occur and be a part of your medical care team without feeling like you're giving up or not having hope about the future. One of our patients on the trial actually brought up an important part. She's like, well, palliative care shouldn't be called palliative care. It should be called the help service, because that's like what we're trying to do. We're trying to help. And so the goals of palliative care can be wide ranging, including psychosocial support, trying to understand like what the diagnosis is, what the prognosis is, because I feel I can't imagine like what you guys are going through, because you go from living an ordinary life to being thrown into this medical world where you have such complex terminology. You have to navigate clinical trials, medical appointments, procedures, all these things that are just so foreign. And the palliative care team can really be an ally in trying to understand everything that's going on. It can also help families establish goals of care. It can also help financially, because it is a huge financial burden to face such a disease, and then also provide symptomatic management. And towards the end of life, it can help with assistance with medical decision making, but it's not just an end of life issue. It's like a throughout the process issue where every family is going to be faced with multiple tough decisions along the road. And sometimes it can be hard to know, well, which provider do I listen to? Whether the providers are providing conflicting ideas, like how do I even like voice my concerns? And sometimes the palliative care providers can be an advocate and like kind of an interpreter, where they can take what you're feeling and interpret it and give it to the medical team, and then also interpret what the medical team is saying and try to help you understand as you try to figure out what you want to do and what's the best course forward. So with regards to the symptomatic management, patients with DIPGs can have a wide array of symptoms where palliative care providers can really help optimize quality of life and comfort. And this can include pain, including neuropathic pain, headaches. Patients can sometimes have trouble breathing, trouble speaking, issues with walking and transferring mobility. And then fatigue is something that plagues a lot of our patients, and sleep disturbances. And mood is something that is very, very important and can really be transformative in determining how a child is able to handle the day to day. And a lot of patients suffer with depression and anxiety as they go through this process. And palliative care can help with that management. They can also help when children have nausea or constipation. And then towards the end of life, it can help when you have concerns for cerebral edema or swelling if the tumor progresses, as well as seizure management. So there's a lot that palliative care physicians can do to help just optimize the quality of life and the time that children have. And something that you wouldn't really expect to be part of the palliative care purview is also just addressing the psychosocial burden, like really being a support system for families, because parents and family members who are going through this, like there's so much that goes on. You lose your sense of self, you lose your sense of normalcy, the normal relationships that you once had have like forever been altered, and you can feel isolated, you can feel guilty. And even though you shouldn't feel guilty, like it's hard, like I can't imagine like parents like that, they must feel terrible when they're facing this. And so having someone to talk to really support you through navigating that journey is incredibly important. And then just from like a practical standpoint, there are economic hardships that parents face when they have a child who has a DIPG. And these figures of median cost of being $184,000 doesn't even take into account the cost of like clinical trials and traveling back and forth for the clinical trial, how your whole life gets on hold. And it's a struggle to make ends meet, even in the best of situations. And so the palliative care team can really help identify resources, and financial resources in particular, that allow you to not worry about that when you're dealing with having a child with DIPG. And then another thing that's very important is the palliative care team can help in planning for the future. Now, this future is not end of life per se. It could just be figuring out, okay, what does my child want to, and what type of treatment am I comfortable with? How long do I want to pursue treatment? What feels right for my family? And then and I hope that parents don't face this, but if at the end there are questions or doubts about like, how do I manage my child at the end of life? Like, how do I ensure that he or she has like a dignified end? It's important to have discussions about things like code status and hospice. And really that it's a very delicate matter to bring up. And I think a lot of providers shy away from bringing it up because they don't want to imply that we're giving up on a child or that we don't want to help. Because we do want to always be there and fighting for children to the very end. But it's important to have these conversations to make sure that there's dignity in the final days. And the palliative care team can help you have those conversations and help you if and when you have to transition to hospice care, and make sure that there's comfort and we always want to place the child first, and they allow you to help navigate that process. And then one other thing that the palliative care team can help you with is if at any point you are thinking about, okay, well, how would I want to proceed after my child passes away? Like, would I be interested in pursuing something like an autopsy or tissue donation? And this is also something I think that is a bit taboo to bring up in the clinical world, just because we never want to make parents feel guilty or make them feel that we are using their children as guinea pigs, or that we are divorcing the child's like sense of self and personhood from their tissue and their body. But it really isn't like that at all. And honestly, like patients who have given their tissue and their bodies to science, like it really helps other patients down the road from going down that same path that they did. But it is an individual family decision. Like no one will ever pressure you to do one thing or the other. Like it is completely okay to not. But I think it's important to know that this is an option, because it's something that could potentially be meaningful to you and to your family, but it by no means is necessary or expected at all. It's just something that's out there. And the palliative care team can help you in navigating those decisions and trying to figure out what is best for you and your family. And so with that, I just wanted to say thank you to all of the families and the patients who inspire us and continue to motivate us to work to find a cure for this terrible, terrible disease. Without you guys, none of this would be possible. So I'm very grateful for this opportunity, and I'm very hopeful that we are able to further advance the cures for DMG. I think working with Dr. Manji over the past couple of years has been incredibly rewarding and inspiring, because the field has changed so much in just the past several years. And when I was in med school, none of this existed. And now we have multiple clinical trials where we're seeing results, and we're having patients living longer, living fuller lives, going to Super Bowls and going off to college. So it really is an exciting time, and I'm hopeful that we can do right by all these kids who are unfortunately diagnosed with this tumor and help them live fuller lives. So that's all I had. I just wanted to open up the floor to any questions or concerns.
Thank you.
Oh, thank you, Dr. Mahdi, so much for attending. We can't tell you how honored we are to have you speak. Does
Thank you for
anybody
having
have any questions? Thank you.
For those of you who don't know me, I'm Regina Karchner from Children's Brain Tumor Foundation. And also, in addition to being a survivor, I was a palliative care social worker many years ago. And I just have to say, kind of based on my experience there, I agree with Dr. Mahdi that palliative care could and probably should be consulted with very early, even as early as at the time of diagnosis. And since we started, this DIPG DMG parent group a little over a year ago, we've had a lot of families who've been able to access palliative care earlier, and they've just had such a better experience with, with things like Dr. Mahdi was saying, nausea, pain management, really helping even young kids share what their wants and needs are in a way that's so much more comfortable, than some of the more traditional oncology doctors. So they're so good at thinking outside the box, focusing on quality of life. And I just love that about palliative care, is that they really can think outside the box and kind of change those medications in a way that, in neuro-onc isn't always the case. So I really appreciate, Dr. Mahdi, that you brought that up as well. And sometimes it's about educating the physicians, especially older ones, that palliative care doesn't mean it's the end. So, and I know we have families in our community who'd be happy to talk to other parents about their experiences with palliative care early on. So do just let us know.
And feel free to advocate. Like if your provider doesn't bring up palliative care on their own, just ask, like, is there a palliative care service at this hospital? Most often there is. So like, if you just don't feel afraid to ask.
We were probably a family that didn't take advantage of it super early on, but we're so pleased when we finally said, could we have a consult with palliative care? Because it really opened up conversations. And with Jace being older, 21 at the time, 22, I thought we were having fairly open conversations, but the team there was so gentle and wonderful. And there's such a blessing to be able to have a good idea of what your child wants. And I would think that those conversations, even with parents of younger children, would be helpful. I was at a retreat with 12 wonderful moms. Actually, it was a girls' weekend. I shouldn't even say a retreat, with but 12 DIPG moms, about a month ago. And, 4 of the moms really just broke down in tears and honestly anger, because no one had visited with them in advance about donating their child's tumor or brain tissue. And they just didn't have that decision ready to make at the time it needed to be made. And I was so thankful that we could have a really good discussion about that early, when it wasn't imminent and we knew what Jace wanted. And so when the time came, even though we weren't expecting it that week, we knew exactly what he wanted, and can be, really proud that he had made the decision, and we were able to follow it.
We have palliative care. We actually got started like as soon as diagnosis, right before we were discharged. They came to us and they said, here in North Carolina, they have transition kids, and I speak to these people very often. I've spoke to the social worker almost every day this week. I have a phone number to text most of these people. They have Zoom called with me, and they're planning. We've had to push their in-house visit back because of certain things, and so but they regularly check on us. They regularly check on me and how I'm doing as the parent, and support our decisions and help with decisions if we need help with any of them. And they always ask if there's anything that they can do to help. Please to let them know. And they see Kenzie and they talk to Kenzie and they entertain her because she's a little wild child. And but you know, if something happens and I hadn't had a chance to maybe talk to my doctor about it, I can talk to them about it, and they can say, well, yeah, maybe message your doctor about this option, because she had, whenever we had got her weaned off, she'd been weaned off for about 2 weeks, but she was still having problems with acid reflux and stuff like that. And so they're like, well, you know, there's some other things you can do, or maybe a different medication. And she's good now. She's not on anything right now, but they did, you know, help with different ideas and stuff like that. So that's just been our experience, and it's nice to have somebody to talk to that, you know, and about your child, like it's like nothing is outside of just her. That's all I got.
Thank you for
Dr.
sharing.
Mahdi, can you speak at all to any early thoughts or correlations with success on the CAR T cell trial between those that are, you know, using steroids at the time that they come to you for CAR T cell versus some, you know, patients that haven't? Can you see any difference or correlation in success?
So it's very early data because we've only had 12 patients, but we think that steroid use does limit some of the efficacy of the CAR T cells. And so we like to make sure that our patients are off steroids for at least 2 weeks prior to infusion. And after getting an infusion, we try to limit the use of steroids. Granted, if it's an emergency situation where we're concerned about increased intracranial pressure, or we've tried all our other interventions and we're unable to get the inflammation under control, we do use steroids. And in fact, the majority of our patients have received steroids and still had clinical benefit and radiographic benefit. So it's not to say that it shuts off the CAR T cells by any means, but we are moving towards trying to limit our steroid use because we think that it might be influencing those cells that can affect how effective the T cells are.
Good to know.
It's still a work in progress though.
Well, we just commend your team for being so brave and trying something that's outside the box. I can remember when Dr. Manji and Dr. Robbie were doing a Zoom call with us, it was like, we don't know how it's going to work. We've done it in mice, and you know, a large population of the mice, the tumors went away, but there were some that died. And so it was kind of a go big or go home in those first couple of patients. But I think you guys have done such a great job in modifying the side effects, right? And being able to treat those and get a handle on them earlier on, and using a number of tools to do that. Would you mind sharing a little bit, like some of the tools you use to, you know, offset the side effects as they come on?
Yes, and it's because of the bravery of patients like Jace that we were able to learn what works and what doesn't work. And I think 2 years in now that we have a pretty regimented way of monitoring patients, and what we typically see is on the day of the infusion or the day after the infusion, kids can sometimes get a headache. They can get some neck stiffness, which is because the cells go through the meninges. So sometimes you can have what looks like a meningitis after the infusion. And at that point, it's just symptomatic management. Then patients can sometimes develop a fever. And once a patient has a fever and is starting to show some signs of maybe neurologic inflammation with worsening of neurosymptoms, then there's a medication called anakinra that we give, and we like to start that medication early. So anakinra is a drug that we give through the IV, and it actually targets the IL-1 receptor, which is something that's very important in recruiting a certain population of cells called myeloid cells. And those myeloid cells are like the bad actors that can sometimes make it so that the CAR T cells aren't as effective as they should be. And by blocking that IL-1 receptor with anakinra, we're able to shut down those myeloid cells and minimize their effect on the CAR T cells. And that also helps with mitigating the inflammation. And so with early use of anakinra, we've been able to really control the severity and the duration of the toxicities that we see. And most patients can get by with just having anakinra. Now, if patients continue to have worsening of neurologic symptoms, or there's concerns for high ICP, then we sometimes use steroids. And then another thing that we sometimes do in conjunction with that, if there are concerns for intracranial pressure issues, is that we use this Omaya that we have as a safety pop-up valve, and we're able to remove CSF through the Omaya and lower the pressure. We haven't had anyone have life-threatening herniation or life-threatening increases in intracranial pressure that we weren't able to control with CSF removal and steroids and anakinra. And so we feel very comfortable with delivering these cells at this dose through this modality. And we like to think that when we have an inflammatory response, it means the cells are doing what they're supposed to be doing, because they're targeting and finding the tissues, the tumor cells in the tissue. And so we think that the inflammation is indicating that something is going on, and we see a correlation in the improvement that we see at our D14 brain MRIs and our clinical exam. So, but those are the main drugs. We used to use another drug called tocilizumab as well to help when we give systemic infusions. And sometimes if patients have evidence of peripheral inflammation with cytokine release syndrome, we still sometimes use that drug, but our main go-to agent right now is anakinra.
Do the patients lose their hair now without using that drug? So there we go.
Chase loved his hair, and we felt terrible when he lost it. But because this new arm is only ICV only, then there is no lymphodepletion chemotherapy that goes. So there's no chemotherapy before him. And it's because it also is ICV. We found, because of the experiences we had with our first 4 patients, that when we give patients CAR T cells through IV, they have greater systemic toxicities, and it's a bit of a rougher course. The first month when you get the IV infusion of CAR T cells, you have more pronounced cytokine release syndrome and sometimes have longer hospitalizations. But when you give only ICV or through the Omaya, you actually don't have a lot of systemic toxicities, and the toxicities that you do have are very well managed with the agents like anakinra, and usually the toxicity window is just a few days. So most patients are only monitored in the inpatient setting for 7 days, and then they're followed locally for 7 more days after that, just because you can't have a second wave of inflammation. Are there other topics? It's really just open to anything anyone wants to ask.
So for those who are responding to the therapy, which there are some, they will continue receiving the infusion in the same intervals?
Yes. And until they no longer. So we have 2 patients that are very close to having a complete response. So those patients, we would continue to give them therapy until we no longer see clinical or radiographic benefit. We don't, it is kind of like uncharted territory. So once a patient has completed or had a complete response, then we still need to figure out, okay, how many more infusions are we going to give? When we'll be ready to like let them fly and see how things go. We haven't really crossed that bridge yet, but we will continue to hopefully treat patients as long as they're continuing to receive benefit.
So which means the ones who are having benefit continue having benefits, so which is pretty cool.
It is very, very cool.
Yes.
And even patients who don't necessarily have as dramatic of a decrease in tumor size, they are still, like we have one patient who is having substantial clinical benefit a year out from therapy, and she's like thriving, and her tumor maybe hasn't shrunk as much as some of the other patients, but she's going to school, she's not walking without a walker, like her eyes are normalized, and it's remarkable to see. So I think like this treatment is really helping improve the quality of life of children, and elongating it as well.
Really thankful in the name of everybody fighting and who fought, because I remember seeing Jasia's videos when he came back. They were like, I was like, oh.
Yeah.
And it's such a personal decision, isn't it, to share how much you want to share publicly, but that was important to Jace, and it's important to Mary Stegmuller's family. So oftentimes you will see on Jace's page, we'll share a little bit about Mary. Her mom, Kristen Stegmuller, is so good about documenting her progress. She's from Colorado, and they weren't able to be on the call tonight, but Kristen did say to please share that they 100% believe this has been just a miracle that Mary needed. She's a kindergartner now. She's back in school when she's not at Stanford. I think I posted a week or so, just a girl in her backpack, because she's playing on the playground, and she sold a ton of Girl Scout cookies to the DIPG community and hopes to go to summer camp. And for many of us to see that at 14, 15 months past diagnosis, that she continually has gotten better over the year clinically is just groundbreaking. And I just keep going back to the bravery of this team, and to know that those starting now are going to try an even higher dose. So, maybe it zaps it faster. We don't know, right? We'll find out, but at least the side effects are so manageable. Her mother describes it as a case of the flu, and she gets it now. And of course, in those early patients, it was a little bit more extreme than that.
We learned quite a bit from those early patients, which make it much safer.
Yeah.
There's this beautiful picture of Jace and Mary where they're on a bridge and Jace is in the back, and then Mary is walking a little ahead of him. And I think it's very illustrative of like how Jace's contributions and his dedication, his bravery to do this allowed patients like Mary to carry the baton forward and live their life.
That was a beautiful day. Mary was scared to walk on the bridge with her walker, and Jace said, "Let me go with you. I think we can do it together." And then partway through the bridge, she passes him, and very metaphoric.
But it is like a decision that's every family has to like choose whichever trial is best for them. It's not, I don't want to pretend like act like a salesman or anything like that. Like every trial has, it could be right for different family. And so it's not to say that if patients or families choose to go somewhere else, that it's a lesser trial or anything along those lines. Like you just have to do what's right for you.
Well, thank you so much, Dr. Mahdi. So if we have any parents on the call that are interested in learning more, who and how do they contact?
Yeah, I can put the email in. It's you can also find the email at the Clinical Trials Gov website. It's GD2CAR-T at StanfordChildren's.org. Let me type it in.
Hello, can I have a quick question?
Yes, of course.
This is Jasia. I'm in Houston, actually, Texas. We have an available CAR T cell trial here. Is that the same, or I guess the question is all CAR T cell trials right now around US, are they the same trial we're talking about, or are they? I think this is offered by Baylor and Texas Children.
Yes, that's a great question. So there are a few CAR T trials. The one at Baylor is GD2, so it is the same target as the one at Stanford, but Stanford's trial is not affiliated with the Baylor trial, so they are two distinct trials. But the community is so tight-knit that Dr. Manje has been like closely involved in the design of the GD2 trial at Baylor, and she's been in contact with the PIs there. And we do recommend, like, if you have the opportunity to go to a trial locally, that I think is probably the best option, just because traveling back and forth can be time intensive. And if it is a GD2 therapy, then it should theoretically be similar. I can't speak to the protocol that they use and like the dosage and the method, but it's something that you could potentially explore. I would encourage you to reach out to the Baylor folks, and then you can reach out to us as well, and we can tell you about the trial, and you can see where there might be differences in the two trials. Another CAR T trial that's currently open is at Seattle. They target a different molecule that's found on DIPGs. And their structure is a little bit different. There's mostly an outpatient trial, but that is another CAR T option.
Thank you.
Would it be safe to say that from what you are learning, if a person's interested in CAR T cell and they can get into one of the trials earlier after diagnosis, it might be worth going for it versus waiting months and months or trying a different trial? I mean, Jace did on 201 because CAR T cell wasn't available.
Yeah.
And I often say that was a perfect situation for him and that he had good quality of life for a while before going back and forth. But I think what I heard you say tonight is, even though it's early, it's maybe advantageous to come after radiation, first radiation, if possible.
Ideally, yes. I think there are some differences in what the efficacy of the different CAR T trials. So I think finding what fits best for you is important, but I think getting into treatments sooner rather than later is what's critical. And it is possible to be on drugs like Ongtilin if you are awaiting a clinical trial and are on the wait list.
And if you are traveling to trial, Lynette, do you just want to address how Mark Jr. Foundation is now able to help?
Oh, sure. Thanks, Lisa. What we're doing is you can reach out to us at info@markjr.org, and we're working together with Chad Tuff on trying to get parents and children to clinical trials. So we're helping them find travel from air to hotels to food to rental cars or Ubers, and just trying to take a little bit of stress off of the parents. So if you know anybody who needs any help with that, please reach out to me. And Lisa is just, as always, a great advocate and refers a lot of parents over to us, and we wouldn't be doing what we're doing without her. So thank you, Lisa. I really appreciate it.
There's so many foundations that are helping with those travel. I see Isabel on the call with Gabriella Smiles, and I don't know, are there 15, 20 different foundations that are plugging in different places to make sure kids have what they need to have the best chance they can get?
And all of the foundations are so open and welcoming and willing to help. It's just amazing. So yeah, so thank you to everybody who has pitched in. Be Positive Foundation has just been instrumental in our success too. So yeah, thank you all so much.
Yeah, we're happy to help from Texas. So yes, we're happy to help. I was actually working on a post for tomorrow. And by the way, my name's Isabel. I say I'm Gabriella's mommy from San Antonio. And today is actually 7 years ago this afternoon. We were in the hospital and doctors told us that our daughter had a mass. The radiologist was he was pretty sure that it was a brainstem glioma. I came home, my daughter stayed home with dad, and the doctor told me, do not Google anything. And what was the first thing I did? I Googled brainstem glioma. And what I found was just terrifying and just horrifying pictures and news. And so the following day, the 17th, was when we were explained, we were told we were taken into a room. Social worker was there, nurse was there, just a big group. The doctor was there, and they basically explained to us what this pontine glioma was, a brainstem glioma. So needless to say, after going through such a difficult time, we lost Gabriela 237 days later. Just right before the 8th month mark, she had leptomeningeal spread disease into her spine. So I think that just complicated and probably accelerated her passing. So just to be able to sit here 7 years later and know that we have been able to help 104 families with financial assistance, DIPG families from all over the country, Florida, California, Washington, just knowing that we've been able to at least do something to help the families while they navigate this terrible disease, but also grateful to know that at least somebody's out there doing something and trying to find better treatments, a cure eventually. So I'm just very grateful to be here, be part of this group and working with Lisa and Lynette and just everyone that we've come in contact with, other foundations, other parents, just so supportive of each other. And it is a small community, but I believe we're mighty. And I know that we're going to keep pushing on and pressing on, because we all are, my website is stronger than DIPG. So we are stronger than cancer. We're stronger together. We're stronger than DIPG. And so I know that there may be parents out there that are, on this call, currently with a child in trial. We do offer financial assistance, provided funds are available, and we try to gift one per month. And so we do have a website, an application on our website. We also have a extensive list of resources on our page as well, other foundations and nonprofits that can help. So just to try to do something and help you all in some way, so that you're able to focus on taking care of your baby, your child. So thanks, Lisa and Lynette, for inviting me to be a part of this. And I appreciate it. And thank you to the doctors that are out there in the front lines doing the work and just trying to make a difference.
No, thank you, Isabel. I mean, when I reached out to you, you didn't even hesitate to offer help. So thank you so much.
You're welcome.
And Isabel is fluent Spanish speaking and
yes,
just a wonderful resource in our parent community for anyone who would benefit from that. So please, please, please always spread the word at Gabriela's Smiles.
Thank you. Thank you so much.
Yeah, and I just wanted to mention that Dr. Mahdi was able to stay this year and work with Dr. Manje due to the contribution of Chad Tuff. We approached Chad Tuff when we saw this whole team scurrying around from taking blood and running it back to the research bench and coming back. I mean, they were out of breath often, let me tell you. And I just knew Dr. Mahdi couldn't lose any more weight on her little 90-pound frame from scurrying around. So we had to find help. So Chad Tuff stepped up and funds now a fellow at Stanford, and Dr. Mahdi is in hot demand. So fingers crossed, we'll get to keep her close, but she will always, I know, make such a difference in the world of DIPG. And then a number of you, some on this call, when we ask, stepped up and funded a nurse practitioner. So hopefully that is, creating some help that they need. And we're able to treat more patients at Stanford.
I was incredibly fortunate and lucky, and I feel very grateful for this opportunity. I could not have expected that it would come my way. And I still remember the conversation that you and I had when you're like, I created this fellowship and I think you should do it. And I was like, I am the fellow. And it was just very fortuitous.
Yes.
And
We were
hopefully
so happy.
I think
Looks like Artis has a question. Oh. Looks like Artis is overseas and it's late.
No, it's probably say, I'm sorry, I'm texting. It's 1:30 here. It's going to come through pretty soon. Right? Thank you so much, Dr. Mahdi.
of course, thank you guys for having me and for being so supportive. I think the question is for the trial, the kids have to be in a specific location. We unfortunately do not have the capacity to treat any international patients, if that's what you're referring to, but we will treat anyone who lives in the US and has American insurance.
I heard there's a trial in Turkey. I don't know where Artis is from. I today saw it appears to be a CAR-T trial in Turkey. So I don't know. Yes. Yes.
And there's also going to be a trial opening up in the UK as well. A GD2 CAR-T trial, actually.
Excellent.
Well, thank you all so much. We
Thank
really
you.
appreciate it. Thank you, Dr. Mahdi. Thank you.
Oh, I
Thank
should
you.
introduce really quick because I just see it on the screen now. Leslie Jared is on the call. If you don't mind, Lynette, we'll just introduce her to everyone very quickly. Leslie helped navigate Jace to ONC 201. And back in January of last year, Jace said, why doesn't everybody get on a Zoom with 5 or 6 doctors from across the US and figure out what the best trial is and have a Leslie Jared help get us to the best trial? And I said, I don't know, Jace, like we're new to this. And he's like, well, we need to make that happen. And we convinced Leslie we needed to make it happen. So you tell your story quickly, and I want to introduce you to Dr. Mahdi too.
Okay, well, I'm in my pajamas. How's that? That's why I was not on screen, but
Sorry
it's
about
okay.
that.
It's okay. It's okay. I'm all covered, so that's good. If you can tell by looking at me, I'm a little bit older than most of you, if not all of you. And I was getting ready to retire, and Lisa said, you need to do this. And I said, well, I'm getting ready to retire, Lisa. I can't do this. And if you know Lisa, Lisa gets her way. And I'm so thankful. I'm so thankful to be able to I hope provide some hope to some of these families that are just devastated. And I came from Cancer Commons, where I worked with Lisa and did a lot of DIPG work and getting people helped with the ONC 201 trial that was very limited at the time. And we pulled some strings that were unpullable in clinical trials and got Jace on even when he by all the rules shouldn't have been on. And what a blessing that was. And so my heart is in this for a while, and I'm not retiring. And we I just have done a lot of jobs in my life, and this is not a job, it's a mission. It's hard to say that it's rewarding because it's such a horrific disease, but to be able to provide some hope, and I do think there's some hope. You heard some hope today. So anyway, I am helping a couple of people, and I also have, Ashley, I hope you're not in your pajamas. That Ashley Duvall, we've just hired, she's a pediatric nurse practitioner, and we've just hired her and going through training. And Lauren Karajas is also, she's not able to be with us tonight. So we are building up a team to help families, and it's just, it's the best. it's the best thing in the worst situation I've ever done. So honestly, and so I'm so glad that Lisa was persuasive. And very thankful that Chad Tuff was able to see the vision also. So I hope you can spread the word, because we are willing to help anybody that in many different ways. It's sort of like Dr. And it's Mahdi said, there's lots of different ways to help. And it's not just, we mostly help with clinical trial placement and trying to get you access when there's not access. So, or when it's just difficult. It's just difficult no matter what. And you're in a difficult situation anyway. So anyway, that's enough.
So lots getting ready to roll out in May, and we're sorry it's taken just a bit, but Leslie is available if, you know, anybody's like in the fight and the trial you're on just doesn't feel right and you want to get to a second opinion or know what else is out there. I mean, that is really the forte of this team. We've got some videos coming that'll provide a little bit better education. I think Dr. Mahdi and Dr. Manji are going to do a couple for us as well. That might be news to you, Jasia. But look, you've done so well now, a 2-minute video won't faze you. And then just this last month, a group of 40 foundations who are parents just like you guys got together, and we're funding a national tumor board to be led by Sabine Mueller and a team of PBTC and PNOC doctors working together that will hear cases newly diagnosed or at progression, whether have a biopsy or not. So things are coming. I know it's never fast enough, but, you know, just keep spreading the word. Or, you know, if you have a family foundation and you want to be part of that, you know, just shoot me an email or a message, because y'all come. We're coming for you, DIPG.
And I just wanted Ashley real quick, Lisa, she's not in her pajamas. That's good.
Hi, Ashley.
If you can just
Hello.
quickly hear her voice, and it helps to put a voice with the face.
Yeah.
Tell them just briefly, Ashley, what you were doing before all this.
So I was at St. Jude. I have been there for 6 years now. I work at one of the affiliate clinics in Alabama. So I worked with pediatric oncology through St. Jude.
Excellent.
So we're happy to have her too. Very happy.
Dr. Mandy, I do have a question, please. When you said about the GD2 CAR-T trial starting in the UK, could you tell me which location it would be at, and when you think it might be available for people to apply to?
So I do not know. Dr. Manji mentioned it yesterday, but if you put your email in the chat, I can ask her specifically which physician and what location it's going to.
Perfect. Thank you so much.
Of course.
Okay, and not to take up too much more of anybody's time, I just want to thank everybody for attending. Thank you so much. Couldn't thank you all. We are so honored to have each and every one of you here. So thank you. Does anybody have any final words? And, you know, Dr. Mahdi, thank you so much. Thank you so much. This was a great presentation. So we really enjoyed it. Thank you.
It's my pleasure. So thank you.
The first of a lifetime, Jasia. You're going to be just on the edge for the rest of your life with us. So welcome.
Well, thank you for having me.
Thank you for joining.
Thank you.
Bye.
We'll see you next month, everybody.
Thank you. Bye.
Thank you. Thank you.